Okay, well, good morning, everyone. Thank you for coming to the Center for Research on People of Color's Anti-Racism Speaker Series. We are so delighted to have Dr. Jide Williams with us today. It's been such a pleasure to be able to work with him here at Columbia University, and I'm just so happy that he's here to share some of the work that he's doing on stroke disparities. But before we begin, I wanted to just give a brief overview of some of Dr. Williams's work. In an introduction to who he is, if all of you don't already know already. Dr. Williams is a professor of neurology and is the Vice Dean of Community Health at the Columbia University Vagelos College of Physicians and Surgeons. He is also Vice Chair of the Department of Neurology and a specialist in the treatment of stroke and cerebrovascular diseases. He is an attending physician at NYP and a clinical neurologist at Columbia University Irving Medical Center. He attained his medical degree from the University of Lagos, Nigeria, and completed his neurology residency and neuromuscular fellowship training at the Neurological Institute of New York. Dr. Williams also holds a Master's of Science degree from the Columbia University Mailman School of Public Health. Dr. Williams is a world-renowned leader in stroke disparities and community-based behavioral intervention research. He is the founder and chair of Hip Hop Public Health, an internationally recognized organization that creates and implements multimedia public health interventions that target and engage young people in the health of their families and communities. He is a principal investigator of multiple NIH investigator-initiated awards and MPI of the Cancer Cardiovascular Disease Center to improve disease outcomes through multi-level and multi-generational approaches, unifying novel interventions and training health equity, also known as community, in New York. An influential clinician educator, Dr. Williams is a member of the Vagelos College of Physicians and Surgeons, Virginia Apgar Academy of Medical Educators, and an inaugural member of BPNS Academy of Community and Public Service. In addition to teaching courses on clinical practice and neuroscience to BPNS medical students, he is actively engaged in addressing healthcare disparities and promoting greater diversity and inclusion in academic medicine. Dr. Williams is co-director of the Columbia Center for Community Health at the Jerome Green Science Center, where he leads pioneering initiatives, including the Community Health Worker Stroke Prevention Program. Dr. Williams has published numerous scholarly articles, including the book Stroke Diaries, and received many prestigious international, national, and regional awards, such as the European Stroke Research Foundation Investigator of the Year Award, two-time Columbia University Outstanding Teacher of the Year Award for the major clinical year, American Heart Association's Trailblazer Award, and a National Humanism and Medicine Award from the Association of American Medical Colleges. Dr. Williams has been named on Fast Company magazine's 100 Most Creative People list, Root 100's Most Influential Blacks in America's list, and New York Magazine's Best Doctors list. He sits on several nonprofit boards, including the board of directors for the Partnership for a Healthier America, whose honorary chair is former First Lady Michelle Obama. So as you can see here, I could go on and on and on, but we are really just so happy to have Dr. Williams with us today to talk to us about stroke disparities, at our anti-racism speaker series. So please join me in welcoming Dr. Williams.
Thank you so much for that introduction, Jackie. I just wanted to make one correction, is that I actually stepped down from Michelle Obama's nonprofit as a director 3 years ago. So I need to update my resume on that, but thank you so much. I'm going to share my screen. So it's a real honor to be here today to give this talk. I'm going to move relatively quickly because we have, I have a lot of things I would like to cover, and also leave time, hopefully, for some questions at the end. So these are my disclosures. So with the Revolutionary War in full swing, on July 4th, 1766, the Continental Congress voted to adopt this Declaration of Independence that was authored by Thomas Jefferson. But interestingly, the distance between Jefferson's ideals encapsulated in this document and his reality made him a somewhat paradoxical hero. Because at the time of writing that all men are created equal, endowed with certain unalienable rights, including liberty, he owned 83 slaves. He also fathered children with one of them, Sally Hemings, and we later have DNA confirmation in that article of 1998 that was published in Nature. Still, Jefferson did believe in freedom for American slaves, but it was his fears that it would trigger a civil war that led him to propose a slower democratic process that would eventually end in slavery. He termed this progressive emancipation. As we know, about 35 years after he died, his predictions that the slavery issue would lead to civil war came to pass. So 4 years after the War of Independence from Britain, 4 years after it ended in 1783, back in England, the Anti-Slavery Society was founded by the Quakers. On the left of your screen is British politician William Wilberforce, who was actually the society's spokesperson. It was Wilberforce who led the parliamentary campaign against the British slave trade. On the right is the society's famous medallion, humanizing the Black man. And you can see an African man in chains on his knees, looking up at anyone who would listen, asking the question, am I not a brother? Am I not a man? Ultimately, Wilberforce was successful in his parliamentary campaign under then Prime Minister William Pitt, and eventually paved the way for the British Parliament's complete abolition of slavery across the entire empire in 1833. So back in America, that same year, 1833, when slavery was abolished across the British Empire, America's Anti-Slavery Society was founded. And this society provided a great platform for Frederick Douglass. Mr. Douglass was an eloquent and literate slave. He was actually secretly taught how to read and write by his slave master's wife. And he escaped to the North via the Underground Railroad at the time. In the North, as a free person, Douglass shared his experiences of slavery and the slave codes. These are some of the slave codes, and you can see how dehumanizing these slave codes were, and the dehumanization of African-American slaves at the time was necessary to continue to propagate the commercialization of slaves. But what was very powerful with Jefferson's talks is that he would often juxtapose these slave codes with the question, what to the American slave is the 4th of July? And it is this rise to prominence, this challenge of our moral ideals that ultimately led him to become a friend and advisor of President Abraham Lincoln. So on April 12th, 1861, after a flurry of Southern states had already seceded from the nation to preserve slavery, Confederate forces attacked a U.S. garrison at Fort Sumter in South Carolina. And this was the event that finally triggered the American Civil War that ended up continuing until April 1865. But before the war ended, in January of 1863, Lincoln issued the Emancipation Proclamation, freeing all enslaved people in the rebel states. This not only inspired slaves to join the Union Army, it also hampered the South's ability to generate income to fight the war. However, it was not until the 13th Amendment in December of 1865 that slavery was eventually ended throughout the nation. And this happened 8 years after Lincoln's assassination. So after the war, the Southern states decided to pass these prohibitive and discriminatory black codes and pig laws. And in fact, America at the time was a tale of two cities. The black codes in the South restricted people's right to own property, to conduct business, to buy and lease land, to move freely through public spaces. It denied them rights to testify against white people in court, serve on duty, on juries, state militias, and even the right to vote. It became a crime to leave a job before the end of their contract. And this was also this period of black codes in the South was also the period that not only witnessed the foundation of the KKK, but also the exponential surge in Ku Klux Klan activity across the South. So one of the unfortunate loopholes in the 13th Amendment that freed the slaves was this excerpt that said that neither slavery nor involuntary servitude, except as a punishment for crime, was exploited by the Southern states, and this led to a whole host of laws, vagrancy laws, that ultimately led to mass incarceration of freed slaves in the South, and the so-called convict leasing of slaves, of freed black men back to the plantations to continue to generate the economy of the South. And this continued for a period, and we still see the remnants of this mass incarceration in today's America. So Jim Crow was actually created. The name Jim Crow was created by an actor by the name of Thomas Dartmouth Rice, aka Daddy Rice. And he really created this name Jim Crow in a song and dance act, mocking and caricaturing black slaves. Around the country, this act was actually extremely popular and was the origin of the black face that's often used as a racial caricature. In fact, the term Jim Crow was actually used as a racial epithet for black people at the time. And the adoption of the name to describe segregation laws, tells you something about those times. Redlining was probably the most impactful of the segregation laws, and it was really created under the guise of residential security. And it simply was a way for loan officers to determine credit worthiness. And at the time, rather than using a financial credit system as a guide to credit worthiness, skin color was the proxy for credit worthiness. So these lines were drawn in neighborhoods all across the country. The redlined neighborhoods were the neighborhoods that received no federally backed mortgages. So homeowners in those neighborhoods, the value of that property just collapsed and crashed overnight because they no longer had federally backed mortgages. A generation of wealth collapsed. The ability, investments fled rather from these neighborhoods. Um, and this is unlike the green-lined neighborhoods. And these green-lined neighborhoods, these were neighborhoods that had the lowest mortgage down payment rates, but they included a racial covenant to keep Black people out. Blue line neighborhoods was not as attractive as these green line neighborhoods, but they also had mortgage friendly loan rates, but again, not as favorable as the green line neighborhoods. And the yellow line neighborhoods, these were the ones that were adjacent to the Black neighborhoods, adjacent to the red line neighborhoods. And these were considered very high loan risks because of the closeness to Black neighborhoods. And they were often very immigrant heavy as well. Actually, Washington Heights, where I'm sitting, is an example of a yellow line neighborhood, and Central Harlem is an example of a red line neighborhood, and the Upper East Side and the Upper West Side were green lined neighborhoods at the time. And so redlining, the reason why it was so impactful was because of its acute effects in just leading to massive disinvestment from these red line neighborhoods, and this unequal opportunity for home ownership and wealth accumulation. The disparities were exacerbated. Already concentrated disparities as a result of slavery were acutely exacerbated by these redlining policies. Poverty was concentrated in red line neighborhoods. And there are additional risk factors such as air pollution, food access, that was again devastated in these redlined neighborhoods. And as you can imagine, this leads to incredible amount of psychosocial stress and coping behaviors that ultimately can lead to poor outcomes that we see even today. And it is the reason why 60% of your health is determined by your zip code. We call these social determinants of health, which is the impact of where we live, where we learn, where we work, and where we play on our health. We now know that zip code is even more important than an individual's genetic code. We also know that your zip code determines the quality of your public school education. We know that revenue to the majority of revenues going to public schools are from local property taxes. You can imagine a neighborhood that's been impoverished neighborhood during redlining, or a neighborhood that's collapsed as a result of redlining and never recovered from redlining. Those neighborhoods would have significantly low property tax revenue and have less well-funded schools. In fact, here in New York State, the inequality gap between rich and poor school districts is about $8,733 per pupil. And we know that this inequality gap correlates directly with the gap in educational outcomes. So there is overwhelming data that continues to accumulate that our zip code is the strongest predictor of life expectancy in the United States. This is some data from NYU Langone Health from 2019, looking at about 500 cities across the country. And you can see the gap in life expectancy between the highest and the lowest zip codes in years. In Chicago, that gap was about 30 years. The gap between life expectancy in the highest zip code versus the lowest zip code, 30 years. In New York, that gap is about 27 years, which is just unbelievable. That we have these types of life expectancy gaps in the United States at this magnitude. Some of our life expectancy numbers rival some of our poorest African countries. just further reinforce the impact of zip code on health, Jens Ludwig did a very elegant randomized social experiment that was published in the New England Journal of Medicine. And this was between 1994 and 1998, where partnership with the Department of Housing and Urban Development, they randomly assigned close to 4,500 Black and Hispanic women and their children who were living in public housing in rich neighborhoods, living in public housing in poor neighborhoods based on the urban census tracts into one of three groups. And so they would receive these vouchers to move to a rich neighborhood. And a rich neighborhood was defined as an area with less than 10% poverty concentration. Or they would just be given unrestricted Section 8 vouchers, or the control group was offered neither. So what they found, they did baseline assessments of these families, the mothers, their children, and what they found 10 years later was that there was a 50% reduction in the likelihood of diabetes and a 40% reduction in the likelihood of obesity among those families who moved from public housing in a poor neighborhood to public housing in a wealthier neighborhood. And what was also interesting, and this was a study that was later published in Science, that there was also a positive effect on happiness and well-being of the families. In fact, there was increased college attendance among the kids who moved from that public housing in the poor neighborhood to that public housing in a rich neighborhood if they moved before the age of 13. However, as one could anticipate, there was no effect on economic self-sufficiency or employment prospects. And so I've talked about the slave codes that we at the founding of this country. And I've talked about the Black codes that emerged after emancipation, which continued through to the end of Reconstruction. I've mentioned the Jim Crow laws that began towards the end of Reconstruction and continued until 1968, including redlining. And I've also talked about the concentrated poverty that's associated with segregation. In fact, legal segregation was replaced post-redlining by de facto segregation, where you found that you know individuals still did not integrate following the dismantling of redlining laws, and segregation has persisted until today. In fact, if you look at what we call the segregation index, and the segregation index is the percentage of people required to move from one neighborhood to another in order to achieve complete integration. If you look at the segregation index today, New York City's segregation index is about 82. And compare that to apartheid South Africa at the peak of apartheid South Africa, which had a segregation index of about 92. In fact, the segregation index, the average segregation index in this country is greater than 60, telling you that this country is still segregated, but this is de facto segregation. And this concentrated poverty that is enabled by segregation, that's emerged as a residual effect of these Jim Crow laws, has led to a persistence in adverse social determinants of health and perceived racism, which has effects not just at the neighborhood level, which I just showed in Jens Ludwig's experiment, but also at the individual level, which I will talk more about. So health trajectories begin in childhood. What we now know is that adverse childhood experiences, and there are about 10 recognized adverse childhood experiences across 3 domains that's been used in research: the abuse category, which includes physical and emotional abuse, the neglect category, and the household dysfunction category. In fact, parental divorce is considered an adverse childhood experience. Incarceration is considered of a sibling is considered an adverse childhood experience. Substance abuse in a parent, etc., are all considered adverse childhood experiences. And there have been numerous studies looking at the effect of adverse childhood experiences and adult chronic diseases. What we now know is that if you have an ACEs score of 4 or more, it's associated when you're an adult with increased odds of binge drinking, risky HIV behavior, diabetes, heart attacks, stroke, depression, all being at much higher odds as an adult if you've experienced any of these adverse childhood experiences. And so the psychology of the African-American child, growing up under these adverse childhood experiences, which is encompassed by the perception of a racist society. Mimi and Kenneth Clark, whose photograph you see here, they actually met at Howard University, and were actually the first African Americans to be awarded a PhD in psychology at Columbia University. And they explored the psychology of the African American child, and they're very famous for the landmark doll test experiments. And in this experiment, the Clarks handed Black children 4 dolls. The dolls were the same, except 2 had dark skin and 2 had light skin. The doll on the left of your screen is actually one of the dolls that we used in the experiment. And the Clarks asked the children questions such as, which dolls are nice, which dolls are bad, and which dolls are most like you? In the 1954 landmark Brown versus Board of Education, this study was actually cited in a footnote, where and in the court's opinion, captured by Justice Earl Warren, he noted that legal separation of Black children gave them, in quotes, a feeling of inferiority as to their status in the community that may affect their hearts and minds in a way unlikely to ever be undone. This video will show you why.
Doll is the black doll. And which one is the white doll?
That one.
Which doll is the pretty doll? Which doll is the nice doll? Which doll is the bad doll? Which doll is the nice doll? And which doll is the bad doll? And why is that doll pretty?
Because she's white and he has 2 eyes.
Which doll is the ugly doll? Why is that doll ugly?
Because he's black.
Which doll looks most like you?
Like me.
Yeah, which one looks like you?
And that one.
Okay.
That doll.
So this experiment it's been repeated and reproduced multiple times. It's also been performed with white kids of the same age, and the results are similar to the responses from Black kids at this age.
Doll is the...
But the damage sometimes actually begins in utero. There is more and more evidence that mothers can transmit their distress to their fetuses. About 20% of maternal cortisol passes through the fetus, which under conditions of stress-induced elevated what we call the maternal hypothalamic pituitary activity, um, it may be sufficient to exert these long-term effects on the developing fetal brain. We also have evidence that the vascular reactivity of uterine vessels to maternal stress may also cause alterations in the blood flow to the fetus. And this high uterine artery resistance has been associated with low birth weight babies as well as preeclampsia. In fact, in a systematic review examining the relationship between maternal experience of interpersonal discrimination with gestational age at birth and birth weight, about 10 of 13 US-based studies found a negative effect of interpersonal discrimination on the birth weight of babies. And the other area where more and more data is emerging is this area of it called environmental imprinting. And this is when studies of maternal relaxation with EKG, cortisol, skin conductance of measures, along with measures of fetal heart rate, and also the use of fetal ultrasound, have also shown that babies, that their cardiovascular state tends to mirror the cardiovascular state of their mothers. We know that this early life adversity related to poverty and traumatic stress varies by race and social economic status. And we also know that chronic adversity, especially during development of a child, in the absence of that nurturing, that responsive caregiving, can actually impair brain architecture. We see volumetric changes, smaller brain areas in the amygdala, which we know is responsible for emotional regulation and conditioning, the hippocampus, which is involved and linked to memory, and the prefrontal cortex, which is involved in judgment, abstract thinking, executive function, etc. Jackie Taylor, who introduced me, is a leader in the chronic psychosocial stress and the epigenetic changes that occur as a result of this chronic psychosocial stress. And we know that DNA methylation, which is the epigenetic change, doesn't actually change the sequence of the DNA, but it can turn on and off a gene. And by turning on and off a gene, you can actually contribute to the initiation of disease by influencing the expression of that gene. In fact, some of Jackie's work on parents of Head Start kids experiencing parental stress have shown DNA hypermethylation of a gene that's been linked to pulmonary hypertension. And so the concern and the evidence that we have is that these epigenetic modifications may be transmittable to children. The children can inherit these changes that result from chronic psychosocial stress that end up causing these epigenetic risk changes. But it also might offer us a window into resilience. There might be some epigenetic changes that confer greater resilience and the greater ability for certain individuals weathering adverse conditions to do so in a way that defies, your average biology. Why are they so resilient? And perhaps these epigenetic changes might give us a window into this resilience. And so toxic stress is the cumulative effect on the body of an individual who experiences repeated exposure to abuse, to neglect, to other hardships without adequate buffering. Adequate buffering is key to the development of toxic stress. Adequate buffering includes the resources that an individual has to deal with stress, both the physical resources, societal resources, as well as the internal resources, and the nurturing, the family structure, the love, all of which we know can buffer the effects of toxic stress. We have now more and more data showing that perceived discrimination, chronic perceived discrimination, microaggression, stereotype threat, all can lead to an earlier onset of cardiovascular disease, results in increased ambulatory blood pressures, lower nocturnal decline of your blood pressure. Most people, when they sleep, their blood pressure falls. In people experiencing toxic stress, their blood pressure might not fall adequately, or it might just not fall at all. Sometimes you could even have a paradoxical response where their blood pressure rises during sleep. And we now know that it's associated with increased cardiovascular reactivity. And so it's not just socioeconomic status. These effects of racism actually cause sickness. And we know that the persistence of a racial difference, say in heart disease mortality, we find it at every level of education, with the racial gap being larger at higher levels of education than at the lowest levels of education. In fact, a Black physician like me, compared to my white peer, has a higher risk of cardiovascular disease, an earlier onset of cardiovascular disease, a higher incidence rates of diabetes, high blood pressure and coronary artery disease, and higher case fatality rates from these diseases. And so structural racism, zip code deprivation, combined with the internalized racism that I showed through the doll experiment, the interpersonal racism, these all have biological effects on us. And it's mediated through chronic psychosocial stress. It causes what we call allostatic load, which I'll talk a little bit more about, but it's basically more inflammation, greater stress response, and overactivity of your sympathetic nervous system. It causes epigenetic changes, which I've talked about. It could cause maladaptive behaviors and affect our mental health, all of which lead to not just the metabolic perturbations that we see with adiposity and glucose intolerance, but also vascular disease and accelerated aging. This was a study analysis done by one of my former mentees, Charles Asenwa, who's now at Sinai, and he looked at historical redlining. He looked at about just over 2,000 census tracts in New York City, and he created these weighted scores for historical redlining. And he computed them using the mean proportion of the original redline territories. And then he overlapped them on the 2010 census tract boundaries in New York City. And what he found that even after adjusting for those social determinants of health that I talked about, and obviously other relevant covariates, the historical redlining score was independently associated with a higher community level stroke prevalence. We also found that, as predicted, that social determinants of health were also positively associated with stroke prevalence. And some of the social determinants of health included educational attainment, poverty, language, and healthcare professional shortage area. And so we know this is some data from the REGARD study. They looked at over 27,000 participants. And we now know that if you have 3 or more social determinants of health, you're 50% more likely to have a stroke. These included zip code poverty, low education, lack of health insurance. But one of the things that I just circled in red here is Black race. And I've been a major critic of using a Black race as race as a variable in these types of analyses, because it's not the race, it's not the color of the skin that drives these outcomes towards the negative side, as we know. It's the experience of the individual with the darkest skin color. It's the racialized experience that really drives the effect, and not the skin color itself. Um, Dr. Gutierrez, who's here with me at Columbia, and we looked at about 27,000 folks from the N. Haynes data set. And we found, again, unsurprisingly, that was a greater prevalence of risk factors, stroke risk factors, which was highest for non-Hispanic Blacks. We found that the stroke was much more frequent in those with suboptimal control of the risk factors. And then what was very interesting was that once risk factors are under control, there was no difference in the stroke rate compared to, especially in those who we looked at with hypertension and diabetes. So control is a key is a key moderator of these outcomes. And when you have a group with greater suboptimal control, and we know with data, but I'm sure all of us can imagine why controlling diabetes or controlling your blood pressure in one environment is very different to another environment. One environment might be hostile, adverse, impoverished, poor access to healthcare. You're struggling with the co-pays for your pharmacy drugs. You ration your pills because you can't afford them. You have increased chronic psychosocial stresses that we talked about that cause additional challenges to your blood pressure. You don't prioritize your health because you're trying to prioritize sustenance and food and shelter. It's not hard to imagine why controlling these risk factors is much harder depending on who you are and where you live. And so is chronic psychosocial stress a CVD risk factor? Is it a CVD risk factor? Is it? And more evidence, especially in the world of allostatic load, is showing that yes, it is a driver of some of the disparities that we see. And we actually also looked at about 704. Jennifer Harris, one of our fellows here at Columbia, looked at about 704 intracerebral hemorrhage patients here at Columbia, and we created a composite measure of allostatic load, and we designed the study to look at the outcome of the TICS score at discharge. A TICS is the Modified Telephone Interview for Cognitive Status. And we found, and we published this a couple of years ago, we found that in Black patients, that higher allostatic load was actually associated with worse cognitive status at discharge, a decrease in that TICS score. Stroke disparities, it's not just prevalence, it's also mortality and incidence. This is another study from the Regards group, and it looks at the Black to white stroke mortality ratio across different age categories. And you can see the younger you are, between the age of 45 and 54, the mortality, the hazard ratio is almost 4. It actually reaches 4 when you get between 35 and 45. The hazard ratio reaches 4. And the reason why it attenuates at 85 plus is really just it's just an artifact of survival. But the point is that these hazard ratios are not limited to mortality. We see them across the board. We see them with incidence as well. We also know that there are lower treatment rates, that people, African Americans are less likely to receive acute stroke treatment, and which includes intravenous therapies at the bedside, as well as mechanical thrombectomy, where we remove these stroke-causing clots in our angiography suites. And we've linked this to a delay in care-seeking behaviors. And we also know, and we understand why more and more now, that Black stroke survivors generally achieve poorer functional outcomes. And our study showed the relationship between allostatic load and, for example, and cognitive function. I want to go back to my point that it's not race, but it's the racialized experience. And unfortunately, for too long, we've been misrepresenting our facts and figures as race, other than the racialized experience. And all this does, is shown in this very elegant New England Journal article, is it propagates physician biases. In fact, one of the ones that I'm alluding to is prevalence without context. If you simply say that Black people have higher mortality, higher incidence, higher prevalence in X, Y, and Z diseases without explaining the context or couching it in the context, it's easy for hypothesis to start tilting towards a biological explanation. Is there something wrong biologically with Black people? Instead of social conditions. And so these disparity figures, these data without the explanatory context, can perpetuate these harmful myths. It can reinforce racial stereotypes about behavioral patterns. It can create biases in our policies and our practices, and it can divert the research priorities and investments away from the real solutions. So I was very excited to see the NIH Phoenix Toolkit, which includes multiple measures of the racialized experience. So this now allows investigators to go to search this toolkit for validated instruments that they can use to measure the racialized experience. And a lot of my work includes using a number of these tools to capture the racialized experience as another variable for analysis. This was a study that we recently published. We published it actually this year in June and in JAMA. And it's a study that it's really a practice-based comparative effectiveness randomized trial led by a colleague of mine, Benga Ogedegbe at NYU. We both were the co-PIs for a U54 Stroke Center grant called SPURP. And one of our projects was a randomized clinical trial where we randomized about 450 Black and Hispanic stroke survivors to either an arm where we included a nurse case manager encountering patients, supporting patients, plus a home blood pressure telemonitoring machine, as well as a home blood pressure telemonitoring machine alone arm. And we looked at the reduction of systolic blood pressure across these two arms. One of the things that the nurse case manager group received are these counseling encounters with the nurse case manager. That include personalized education and disease management for patients. The nurse helped the patient set behavioral goals, e.g. with physical activity, with weight loss, with dietary changes, even with medication adherence. The nurse helped address the patient's progress, the patient's challenges, specifically related to social determinant of health barriers. If a patient's blood pressure, for example, was above target, the nurse notified the patient's provider and helped facilitate medication adjustments and also refills as needed. And so we found in this integrated nurse case manager model that effects on systolic blood pressure was huge. At 12 months, we found a 15-point reduction, a 15-point reduction in your systolic blood pressure. That's a massive effect size in the nurse case manager arm. But we also found a really strong effect in the home blood pressure telemonitoring arm of about 5 points reduction in systolic blood pressure at 1 year. And this just shows that by integrating social determinants of health support and more counseling and coaching support for African-American patients, we can achieve really huge blood pressure reductions. And we know the blood pressure is the biggest driver of stroke in the population. I also think it's important that the way we educate patients, especially culturally tailored education, is also very, very important. I've done a lot of work in my studies looking at cultural tailoring of our educational intervention. This was a study we published in JAMA Neurology that showed the effect of education on a stroke preparedness. We use a validated instrument of stroke preparedness, and you can see the education effect with low education among Hispanic and African Americans. You can see the dissociation of the usual care and intervention arms, with the low education group significantly benefiting from the culturally tailored intervention relative to how we typically educate individuals and build their health literacy. For the sake of time, I will not show this, but just to summarize, we've also done interventions with children, using children to bring literacy concepts around stroke to their parents and their grandparents using hip hop. Transmission back to hypothesis model was studied in a large randomized controlled trial that showed that using a hip hop themed approach with music and video games, we can actually not only improve the stroke literacy of the children around stroke concepts, but also transfer that to their parents, and also that these children also can be agents for calling 911 when a grandparent or a parent has a stroke in the household. And also we found a reduction in pre-hospital delays in a quasi-experimental design as a result of this intervention. My latest intervention is in partnership with Dr. Randy Marshall, where we've created a social determinants of health intervention focus team, again, to mitigate those midstream effects of health that are being caused by social determinants of health. And so we're randomizing about 250 African American and Hispanic patients with 3 or more stroke risk factors. Remember this study that I showed that says having 3 or more stroke SDOH increases your stroke risk by 50%. So we're randomizing this high-risk group of people to either usual care post-stroke or to receive this shift team intervention. And Jackie Taylor is one of our co-investigators, and she's going to be looking at our epigenetic markers before and after the intervention. Our primary outcome is looking at functional outcomes using the stroke impact scale. We're also measuring physiological outcomes related to blood pressure changes and cognition based on some of our pilot work. And we're looking at these effects at 6 months and 1 year. What we are hypothesizing is really driven by some of the findings we saw in the study we published in JAMA with nurse case management, that a nurse, a community health worker, and a community social worker dispatched to the patient's home after a stroke, supporting that post-stroke patient in his or her recovery, will lead to better outcomes than our usual care approach, which is just to have them follow up. The rate of recurrent stroke is exceedingly high in these populations, and our goal is to reduce this by introducing the SHIFT team. The community health worker, just as an example, is involved in referrals, food insecurity, housing, immigration, employment, helping with the patient portal, for example, telehealth visits. And this is just a quote from one of our CHW's experience with a patient in EPIC. The assessment was conducted during a home visit. The client was accompanied by her husband and gave me verbal consent to participate in the conversation. I discussed her care goals. The first goal we talked about was for her to find a PCP, primary care physician. With social work assistance, she was able to find one, and the appointment is scheduled and transportation arranged. We also talked about food insecurity, and I will refer her to Food Pharmacia. I will also put together an emergency groceries to give the family. This is just a window into what some of these stroke patients are experiencing above and beyond the condition that they're dealing with. The social determinants of health is now being addressed system-wide, especially for Medicaid members. Governor Hochul recently created these social care networks across the country to help address these social determinants of health and integrate it with the healthcare system. But wait, surely DEI is dead. Surely DEI is dead. With the election, or re-election rather, of Donald Trump, we anticipate a backlash, including more restrictive legislation and additional blows to the DEI movement. However, we have been here before. One only needs to imagine or look at our coalition. Look at the women's movement. After the suffrage victories of 1920, they said the women's movement was dead. It came back in 1960s, and they said it was reborn. The LGBT movement, Q movements, following the March on Washington, they said that marriage is impossible and will never be enacted for lesbian and gay couples. We reached that place where gay and lesbian couples can now get married. And we've already been through the African-American journey from Harriet Tubman through Barack Obama, through the great accomplishments of the first women vice president who was African-American, Kamala Harris. The reality is that the pursuit of justice and fairness is fundamental to our well-being. It is inextricably bound to the pursuit of happiness. It is unalienable. The human pursuit of equity, of inclusion, and belonging does not die. Rather, it enters a state that has been called social movement abeyance. In hostile environments, it waits in the shadows, organizing, strategizing, bonding in forums just like this one, championing anti-bias mitigation in affinity groups of organizations, reframing the issue, building allyship. This is John Newton. He was a young, brutal captain of British slave ships that traded along the West African coast, actually along the coast of Nigeria, where I'm from. After years of describing himself as delighting in evil, he subsequently became one of the greatest allies in the anti-slavery movement. In 1748, while at sea, he encountered a severe storm that almost took his life. That near-death experience led to his conversion to Christianity. He rejected the slave trade and entered the priesthood of the Church of England. Amazing grace, how sweet the sound that saved a wretch like me. I once was lost, but now I'm found, was blind, but now I see. Many people don't know that this is the man who wrote Amazing Grace. He is a man whose journey continuously fills me with hope. In fact, Newton later became the counselor and spiritual mentor of one of the greatest abolitionists of that time, William Wilberforce. And he guided William Wilberforce as he led the successful struggle against the British Parliament to end slavery throughout the British Empire. Thank you for your time.
Wow, thank you so much, Dr. Williams. What a very powerful message, particularly now in the times that we are in, and great encouragement for us to continue and to strive for health equity on all fronts. I don't know if we have any time for questions, but maybe one or two. And if there's anyone from the audience that has anything they would like to add, but I'm just, so happy to see how you have couched the rationale of why we need to do the work that we do in health equity in the historical context and modern day socio-political climate, because it's important to know where we started, what are the things that have influenced us in this nation, and where we need to go. So again, I want to thank you for all of the work that you're doing to improve the lives of many people, not only here in New York, but across the country. We are very blessed to have you, and I'm so proud to be working with you here at Columbia University. So again, thank you so much. We would also like to thank, I didn't do this in the beginning, but I want to thank the Office of Faculty Development and Dr. Dennis Mitchell for a grant that supports this anti-racism speaker series. And we also want to thank the staff and affiliates of the Center for Research on People of Color for their continued support. So thank you again. And it's wonderful to hear from you. And we want to continue to see the results of all the great things that you're doing for us here in New York and beyond.